Welcome. I am Terry Tropin, and today I'll be discussing coding a nursing facility visit using the 2023 guidelines for CPT's evaluation and management codes. First, let me tell you a little bit about myself. I have a master's in healthcare informatics, health administration informatics, and I have these credentials. I'm also an AHEMA approved ICD-10 CM and PCS trainer. I taught for over 20 years at Montgomery College in Maryland. I also have some books. Here are my books, and they are available on Amazon, and they're updated every year. So my books are one on evaluation and management coding, one on ICD-10 CM, and one on ICD-10 PCS. These books are study guides that summarize the coding guidelines, including the 2023 changes. And as I said, they're updated every year, or more often if necessary. So this is what I'm going to be talking about today. I'm going to present a nursing facility case, and then we're going to take that case and step by step figure what would be the medical decision making for this case. And then we would determine which code would be selected if using this medical decision making. Then we determine which code is selected using time only. Remember, you use either medical decision making or time. So this case is in a skilled nursing facility. Remember that nursing facility and skilled nursing facility cases are coded using the same codes. So how do we know which is which? See the place of service codes in the beginning of your CPT book. A nursing facility visit uses a place of service code 32. A skilled nursing facility visit uses a place of service code 31. So this is the category for nursing facilities, and there's subcategories. There's initial service, subsequent service, and discharge services. So these first two use medical decision making or time to determine the correct code. Discharge services use only time. The time is expressed as a specific number of minutes which must be met or exceeded. So if a code says 20 minutes, you have to meet at least 20 minutes. It may be a little bit more, but it's got to be at least that 20 minutes. So here is our case. This patient has been residing at home until an episode of pneumonia resulted in hospitalization. While there, it was determined that he really was not able to remain in his home on his own due to rapidly advancing Alzheimer's dementia and episodes where he tried to wander away from the hospital. He lives alone and has no family in the area, so no family support. He was transferred to the skilled nursing facility because of this condition, although no specific therapy was ordered. The pneumonia had completely resolved in the acute hospital and no further treatment was needed in the skilled nursing facility. The patient was admitted by a physician assistant who did a basic intake. The principal physician saw the patient the next morning for 55 minutes and reviewed the case. Now remember that the guidelines for these nursing facility codes define principal or admitting physician and other healthcare professionals, like the physician assistant in this case. The guidelines state that in a skilled nursing case, such as this one, initial care must be provided by the principal physician. So even though a physician assistant performed the initial intake for this patient, the physician who saw him the next day can still report an initial nursing facility code. So initial doesn't necessarily mean first time the patient was seen. It just means the principal diagnosis for skilled nursing facilities. Okay, so the patient does have underlying COPD, hypertension, and heart disease that require daily medications. Since the patient is on multiple medications, the physician performed a review of the drugs and their dosages and screening for drug-drug interactions and drug disease interactions. So those side effects that can be really very important. Discussion with the hospital staff and patient reviewed results of the screening. This patient has multiple conditions as receiving multiple medications. So for the COPD, for the hypertension, for the heart disease, two different conditions, two different drugs, and a drug for the dementia. So as you read through any case, it's important to underline or make notes to pull out the information you need to determine the correct code. Some cases will go on for pages and pages and pages, and you don't want to have to keep rereading the same material in order to answer a question that you have in order to about how this should be coded. So if you underline the information or make notes, then you can just use those to figure out what the code is. So how do we know what to underline? Well, that comes from practice. So as you become more familiar with the codes, you'll say, hey, we need to know that. Hey, that's important. And that comes with practice and underlining, and practice and experience. So what do we need to know and underline in order to select a code in this specific case? So you need to know rapidly advancing Alzheimer's dementia, so the condition that is getting worse. He lives alone and has no family in the area to help him. That's also important. He's in a skilled nursing facility, and the principal physician saw the patient the next morning for 55 minutes and reviewed notes from the hospital stay. So there's a lot of other information in here, but you don't really need that in order to select the code. We also need to know about the conditions and medications. The patient has COPD, hypertension, heart disease that require daily medication. Since the patient is on multiple medications, the physician performed a review of the drugs and their dosages and screened for drug-drug interaction and drug and disease interactions. He also discussed with the patient with the hospital staff from the acute hospital and also with the patient to see how he was doing, to see how the dementia was going. Reviewed the results of the screening. Okay, so here's a list of the conditions and the drugs being given and possible side effects. COPD, hypertension, heart disease, dementia. What kind of drugs are being taken and what are the possible side effects? Are they dangerous? Is the patient at risk? So after we look at all this, let's look at selecting a code for this case. First, we'll look at the level of medical decision making. So medical decision making is made up of three components: the number and complexity of problems addressed at the encounter, what's wrong with the patient, and how serious are the condition or conditions. Amount and complexity of data to be reviewed and analyzed. How much information does the provider have to gather in order to determine either what the diagnosis is or how the condition should be treated for this patient. And then we have the risk of complications and morbidity or mortality of patient management. This is the risk of the treatment, not the risk of the disease. The risk of the disease is in this one. So we have levels of medical decision making. So all these three components will be used to determine a level of, together will determine whether straightforward, low, moderate, or high. So just to make things a little more confusing, there is a special component of medical decision making used only for nursing facilities and used only for patients considered at high risk. So this component is multiple morbidities requiring intensive management, a set of conditions, syndromes, or functional impairments that are likely to require frequent medication changes or other treatment changes and or reevaluation. So the physician has to go in and check on the medications a lot, several times, frequently. The patient is at significant risk of worsening medically, including behavioral status, and risk for readmission to a hospital. So this is used only for nursing facility patients. So let's look at the first component of medical decision making, the number and complexity of problems or problems addressed at the encounter. So we have straightforward, one self-limited problem. Well, that's not right. That's not it. Low, two or more self-limited minor problems, one stable chronic illness, Well, they have some chronic illnesses, but the most important thing is the acute condition. So that doesn't fit. Moderate, one or more chronic conditions with exacerbation, two or more stable chronic illnesses, one undiagnosed new problem, one acute illness with systemic symptoms, one acute complicated injury. Well, sort of, but it's actually more than that. So let's look at high. A high risk of problems addressed, one or more chronic illnesses with severe exacerbation, or one acute or chronic illness or injury that poses a threat to life or bodily function. I think we've got a winner here. The patient has a number of serious conditions. The worsening dementia is definitely a threat to life or bodily function. So this will be high, threat to bodily function. So medical decision making for the component problem to address will be high. So let's look at data reviewed, the second element. So we have, this is the amount and the complexity of data to be reviewed and analyzed in order to decide treatment or what the diagnosis is. So straightforward, no, this is not straightforward. If it was straightforward, they wouldn't be in a nursing facility. Low, you have category 1, category 2, either category 1 or category 2. We've got some stuff for category 1, but it's more than that. Moderate, meet at least one of 3 categories. Now notice on this one, independent historian is lumped into category 1 here, and for low is its own separate category. So this is a change between low and moderate. The same criteria are listed for high, but the difference is that in moderate must meet at least one of the 3 categories. In high, you must meet at least 2 of the 3 categories. So same categories, it's just a matter of how many need to be met. This is also high. Review of external notes from hospital stay, order and review of screening results, and then discussion with the hospital staff. So we can count review of external notes, ordering each test, review of results of each test. So for the screening, you can count ordering and reviewing. So for category 1, the ordering and review of the results are counted separately. Remember that a review is counted only as ordered or reviewed, and interpretation is counted twice as ordered and reviewed. This was clarified in the March 2023. So what's the difference between a review of results and a interpretation of results? A review is a simple going over of the results of a test. The patient is pregnant or not, so like that. An interpretation is much more involved and can therefore be counted for ordering and reviewing. So the physician is ordering the screening, looking over the results, saying this drug deals with, interacts with this one has this one, what kind of problems can arise using these drugs. So that's why I counted it as 3. Discussion with hospital staff. So the physician called the acute hospital where the patient had been transferred from and said, let's go over some of this, what's your impression of the patient, etc. So we have data reviewed. So let's look at risk. The final component for medical decision making. This is the risk of treatment, not of the condition. Remember, the condition is considered in the first the problems addressed. So we have straightforward, well, obviously not. Low, no. Now look, moderate and high have only examples. So moderate says drug management, minor surgery, elective surgery, social determinants of health. Now we have that. Remember, we said that the patient lives alone and has no one to help them, and they're wandering. So that's a social determinant of health. However, look at the examples listed under high. We have that multiple morbidities requiring intensive management. Okay, so have to look at the drugs, check them often to look for interactions. So I would say that this is also high. Excuse me. So the three elements are the social determinants of health and multiple morbidity, and this is high. Okay, so we have medical decision making. This is easy. All the elements are at high, so the medical decision making level is high. But remember, we might be able to do towards time. So remember, we have that bucket of codes in the category nursing facility, and they're divided into subcategories: initial nursing facility, medical decision making, initial nursing facility, subsequent, and discharge. So we're going to do from this range. So the code in that range that's for high medical decision making is 99306. Remember, the time was 55 minutes. The code in the subcategory and code in 99306 says 45 minutes. This says 55 minutes. So it's met the baseline of that, but it's a little bit more than that. So by 10 minutes. This is not enough extra time to use a prolonged services code, but it does give you the base of 45 minutes. I'll talk about using prolonged services in another practice video. So we're going to select 99306 for this case based on both medical decision making and time. So either way gets you to 99306. That completes this video. If you have questions or comments, please feel free to contact me. For a practice case in an outpatient setting, see Practice 1. For a practice case in an inpatient setting, see Practice 2. For a larger discussion of E&M coding for 2023, see my other videos, 2023 Evaluation and Management Updates. Here again are the books I have written. And here's the link to Amazon for them, though you can just go to Amazon Books and type in my last name, Tropin. You can contact, I have a couple of podcasts, Facebook, you can email me. If you want a copy of the slides, let me know. If you enjoyed this video, please give it a like and subscribe by clicking on the photo, my photo in the lower right-hand corner. Thank you very much for listening. Thank you. Thank you so much for listening. Remember that I have a Practice 1, which is on an office visit, and I will do additional practices in the future. Thank you.